And we're live. Hi, everyone. Welcome back to Diversity with Diana podcast series, the podcast that discusses inclusive diversity and good governance. Today, I'm really excited to get back, first of all, to sharing diversity stories, inclusion stories, and good governance. Today, we have a special guest in studio with us. I want to read his profile from what I have compiled online and on his social media. This is Dr. Simon Kigondu, a husband, a father, a social thinker. Dr. Kigondu is a medical doctor specializing as an obstetrician, gynecologist, and is based in Nairobi, Kenya. He is a health advocate and the CEO of Excella Healthcare, an obstetrics and gynecology practice based at KMA Centre, Upper Hill in Nairobi. He currently serves as a Secretary General of Kenya Medical Association. He also serves as a board director at Amnesty International Kenya. We engage Dr. Kigondu today to understand the merit of inclusion in Kenya's healthcare system and policy. We ask, do all persons in Kenya of all diverse backgrounds have similar access to healthcare services without discrimination? We discuss this and much more today. So karibu sana, Dr. Simon, and thank you so much for honoring our invitation.
You're welcome. Thank you very much, Diana, for hosting me in this podcast. And we hope we learn something new. And I'm interested in engaging your viewers and probably one-on-one direct from their questions following the introductions would be very useful.
Right. Karibu sana. So we usually have the introduction where we have our guests tell us about their journey. So as Simon, not the daktari, before you became doctor, who you were, probably your family history, how you became to become a doctor, what were your motivations, inspirations, and then becoming successful in your career and becoming that voice of reason. Yes, daktari.
So I was born, but do I say, at the Aga Khan Hospital. My father those days was a thinker, a bowler, so to speak. But Aga Khan Hospital was like the Kiambu District Hospital because their shags was there in Kiambu, Moshada there. So that's how I happened to be born there. That was a long time. But recently we celebrated my mom's 69th birthday, which can be found on social media. So I think my parents contributed to a lot of where I am now. And luckily for me, they are both still alive. They live there in the home of Caliph Records, there in California, if you want to visit them. I have a brother and two sisters, and two children, and a nephew and a niece. So I'm a born town, so to speak, a Nairobi fella.
Clearly.
Having grown up in California, that's East Lando, so to speak, but went to Lavington Primary School and Strathmore School, and also Strathmore College, and eventually the University of Nairobi to do medicine. The reason I did medicine was, I think people who had high marks those days just chose medicine. And we went there, and 6-year journey in medicine. Then I was posted to Machakos District Hospital then after for internship and being a medical officer. I returned to the University of Nairobi to master in obstetrics and gynecology. And after that, I was posted as the gynecologist, medical superintendent, and director of medical services of Isiolo Zone. I was in charge of like 8 hospitals, but the main one was Isiolo District Hospital. So I worked in that Asal area for about 5 years. And then I moved closer to Murang'a County Hospital, and currently also in the public sector at Kegumo Sub-County Hospital. Throughout, I've done private practice, and I think a combination of both private and public practice makes for a good doctor. We supplement the government with private practice a bit, because I suppose you can never pay the health worker or indeed any other civil servant enough to probably survive in this time where fuel is 135 bob per liter.
Liter, nakwambia, we are suffering here in Nairobi, but some of you are born town, maybe you're used to this high cost of living. Yes,
Yeah.
Daktari. So, yes.
Yeah. So in terms of health leadership, I've been I became the chairman of Kenya Medical Association Machakos division immediately after finishing internship those days, in the year 2001 for 2 years. I've also been in several committees of Kenya Medical Association, rising to National Treasurer, then Secretary General, which is my current designation. I'm also a council member at the Kenya Obstetrical and Gynecological Society. A council member, the sort of the governance, as the sort of chairman of the central branch of the association. In terms of justice scenarios, I am a board member of Amnesty International Kenya, because I espouse those values of protecting yourself from power, so to speak, you know.
Yes.
Kupigania wanyonge ambao hawajiwezi.
Right.
So, yeah.
That's very critical, and thank you so much for bringing us into your leadership journey as a medical doctor and just showing us that that training, what you have done, how many years you've actually done in the Asal County. I had no idea about that. But today we want to understand something, Daktari. We want to understand about health policy in Kenya and its practice. And then later we'll ask you whether it is inclusive, whether we as advocates, human rights advocates, should focus on healthcare being inclusive to young people, women, persons with disabilities, economically unstable persons, and basically all the people in Kenya. So let us understand the context of the health policy and practice in Kenya. Yes.
Yeah. So Kenya is known for having some of the best policies. We come to fighting about the implementation. So about having on paper the policies that are good, we do have. So the Kenyan health system is divided into a public and a private healthcare systems that run concurrently and are supposed to be complementary. And of relevance is that the government is supposed to sort of do two things: run the public health system and give a suitable environment for the private health system to thrive. So there are many factors that need to be in place on that. The picture from it is that health is a social good. Health being a social good, and every Kenyan has a right to the highest achievable health care according to the Constitution, then it is upon the government to ensure that every Kenyan has access to the highest possible care in this country. And as a result of that, health being a public good and health being expensive, then it is important that finances be allocated to the provision of public health care. As an individual and as an association, we have advocated for what is called tax public-driven and tax-funded public healthcare system. And this is with the understanding that health is expensive. In health, you have the private sector, which is the basis of a private sector healthcare is profit-driven. A profit-driven entity cannot be used to run a country's health care system. Profit-driven system, the private sector has every right to be profit-driven, and maybe later when we come to the conflicts that we see where people are complaining about being charged fees, then you'll see that it is not the problem of the private health system. It is actually an economic question. So a lot of people complain, not because of anything, but because of their economic situation that does not allow them to get the highest possible quality of care, which we have said is a right. And everyone wants the highest possible quality of care, and we do. And therefore, this brings the clash, so to speak, in people's mind on these healthcare provision. So when we advocate for public-led, tax-funded, this is so as to enable, and this is the concept of universal health coverage, which is to ensure that everyone gets the highest quality of care without going into financial catastrophe. As you know, one illness can make a whole generation poor. You see, if you are to take care of just one illness, and the hospital bills are very high, then a whole generation, whatever you did, can all go down in one stroke. And we have seen this in the COVID situation, whereby you are thinking you are well off, you have your house bought, you have your cars, you have maybe other property, and you see that the disease on one parent, for instance, or both, so to speak, because COVID seems to be affecting out, has taken out a whole generation's work and investment. And with that understanding, therefore, we as a people must push the government to ensure that everyone can afford medical services. And in my view, the only way of doing this is to ensure that everyone has some form of health insurance, meaning that when they enter into any public institution, then they can get treatment without having to worry about cost, and that they have to go to you do not have to be choosing between disease and poverty, you see, so that if you are not able to afford, then you cannot take care of your disease. From a bird's eye view, the way we have to look at healthcare is that once someone is unwell, they need to be treated quickly so that they can go back to the community to become a productive member of the community. If that disease is not treated, not only can't you work, but you become a burden to everyone else around you, so that all resources are directed at looking after you because you did not get timely, quality health care. And therefore, if we look at it from that point of view, then we will understand the need of pushing the government to ensure that everyone can get this quality treatment early, quickly. Sorry, I can talk the whole day on this, but let me just continue.
I know. I was actually going to interject and say, you've literally answered the next question that we had, which is, do we have just and fair access to healthcare services? And maybe to ask you, Daktari, so we don't want to hear a rhetoric or maybe suggestions, like what is being done? Because good thing we had that you're saying you're a social thinker and you're an advocate. So what are some of the, let's say, I don't know how you call it in the public medical spectrum, but where we sit is that we sit in our governance space. This is youth governance space. We sit with the youth legislators, whether in parliament, in the Senate, in positions of authority, and we ask them, we give them our agenda points, and we tell them these are the priorities that we want for inclusion. And then we push them and we keep them to task. And they come back and report to us as a youthful population. and especially those of us in member organizations. So for the medical professionals, you as a social thinker and as a practicing medic, also sitting in high level positions, what have you done to help change this lack of fair access, if I could say that, or there may be unfair distribution of resources that don't go towards service delivery, health financing, and probably poor governance? What have we done? Like, can we hear at least a bit of hope, and knowing that you are one of the advocates that are pushing for us to get this fair access to healthcare services? Yes.
Yeah, no, it's not all gloom and doom. Yeah, and from the top, we must actually thank our president because for the first time, health has been prioritized in the national agenda. Among the big four agenda, we have universal health coverage. So you must understand that you can go on strike, you can make all noise in the street, but if your agenda is not at a policy level, then you will not get that funding. So the fact that universal health coverage has actually been pointed as a government direction, then you have funding directed at that. And that's the first step towards improvement of healthcare. We had fought for that for a very long time. And for a long time, health was not prioritized. But with the big four agenda, then that has actually been done. Secondly, is that we know that the system building blocks for a good health system include there are 6 building blocks: service delivery, health workforce, health information systems, and access to essential medicines, financing, leadership, and governance. At the level of the health workforce, what we are saying is that the World Health Organization ratios of health workers to for the necessary service, the ratios have not yet been met. So the first thing maybe your youth may need to follow up is a proposal of what we call a health service commission. A health service commission would be a commission that employs all manner of health workers and distributes them across the country to meet the ratios that are necessary for that. So that is an agenda we've been pushing for. We had put it in the constitution, but they relegated it and removed. And therefore, when that question you're asking me about that surgeon who goes on leave and there is no other surgeon to replace, then a health service commission would help in getting that. The other agenda is financing. The Abuja Declaration put health financing for you to get quality healthcare at 15% of the national budget. So our 3 trillion budget, we need 15% of that pushed to healthcare, and that would help. And in terms of access to essential medicines, then these issues of KEMSA, if you know what we mean, then we would need to ensure that there is good governance in the procurement system across the board. In terms of health products, you need to push and ensure that the government does not charge for health products. For instance, someone who needs an implant, it becomes unaffordable because you have tax on it from the government, then transportation, fuel is expensive, they add another fuel, you transport it, and then the health products become expensive, and therefore you cannot afford them. Then in terms of health information systems, we need this information on health collated and put as information. And then after that, you don't only have information, but you act on that information. So when we say that there is no surgeon in ABCD place, then you send a surgeon, not giving excuses that, oh, we do not have funds to that. But the information has shown there is a need for a surgeon. In terms of disability mainstreaming, for instance, then you have, you need to ensure that you are thinking health not as treatment, but as both prevention and facilitation of health. For instance,
Right.
Health goes beyond like city planning. If someone was blind, they are supposed to be able to get from wherever they are to wherever they need to go without having been pulled in hand. So that's part of city planning. If someone is going from one place to another on a wheelchair,
Yes.
that they need to actually be able to go. And now, in terms of the levels of government, when we devolved healthcare, we have beef with how the devolution was done. The idea, though, was as this: the county governments under the governor were supposed to be in charge of preventive, promotive healthcare. And then at the national level, then you have the curative, or the big hospitals and the staff thereof. And in between them, then you would have a referral mechanism, which is what is called pre-hospital. How do you refer from one place to another? So at the county level, the health means, and this was brought out excellently by COVID, it means that you have preventive measures which include water and sanitation. Even just by sorting out water and sanitation, you prevent 90% of diseases.
Right, and transmission of them,
Correct. And therefore, you prevent the health system from being overwhelmed by useless diseases like cholera. You see, that is the role of the county government. They know well. In terms of housing, then county governments are the ones that give licenses, for instance, for infrastructure and building. Now, the pediatrics will tell you that the rate of rickets, which is caused by lack of sunlight, is very high in these high-rise building places. What is the problem is that the building and construction does not allow light to enter for babies to get. You see, that is under the purview of the county government. And by the time you get rickets, then when you grow up, then you will be unable to deliver normally because your pelvis will be small. You did not develop your bones. You see, you have long-term kind of effects. So that shows that the role of the county government in actually preventing obstructed labor, so to speak, in terms of county government. In terms of the environment, then you need the county government to ensure that mercury is not being dumped into the Nairobi River. And when you get mercury, arsenic poisoning, then there's a problem. They need to ensure that the water that they serve has been cleaned well. So those are the roles of county government. And then
do they understand these roles? Sorry, Daktari, do they understand these roles? Because I'll tell you this, and I've been in the governance space for a while, but I didn't know that it's that deep, that the whole point of devolving healthcare is for, you said, preventive and promotive at the county level, and you only leave for, the curative role of it in the national level. I don't even think I've ever had it expressed this way. Who is holding this information that it's not reaching out to the public?
So there is policy and there's practice. So part of the reason that the county governments wanted the curative services is that prior to the devolution in 2013, the government policy on health was termed reversing the trends. There were bad trends in health, and they sat down and came up with what is called reversing the trends policy, whereby people were charged with ensuring that health facilities become not only sort of centers of excellence of treatment, but centers in which money is collected and money is used to run the health facilities. So that by the time of devolution in 2013, the hospitals had improved so much and they were doing so well in terms of revenue collection that they were seen as sources of income. But the background to that was that the health workers were involved in ensuring that they run the health facilities, ensuring there's no leakage of funding, and that the monies collected by the units are actually used towards improvement of the health facilities. I ran one of those for 5 years in the ASAL called Excella District Hospital. And just from the top of the head, we can say that the revenue collection improved fourfold in those 5 years. the hospital moved from one consultant hospital to an internship center, which requires a minimum of 4 consultants. The services increased exponentially, and we reduced the referrals, and we collected more money, you see, and people were happy, so to speak. We also ensured that we protect the community by enrolling them into the National Hospital Insurance Fund, NHIF, such that if you had one person coming and you enroll them and their whole family, then the next time they come, you have protected them using enrollment from NHIF and some form of medical insurance. So that is the kind of symbiosis we have had between the county and the community and the health facilities. The health facility was run by 2 committees. One was the hospital management team, which was the technical team. Then a hospital management committee, which was headed by a member of the community. And in that meeting, they would bring the community needs, and we try to improve it in the hospital and all. We also had the team from the county, the public health team, that was going out to the community to administer, how to see, facilitate referral and things like that. So those may have been some of the things that may have been lost as a result of the
in translation. Yes. And I just want to bring in a comment from one of our viewers. I know she's also a medic. Her name is Diana Sifuna, tuning in from the United States. And she's actually posing a question towards universal coverage. And she says universal coverage is a good idea, although it is viewed as an innovation killer. Shifting this from government to the public, from participation, education, curriculum, involvement, and so on and so forth. So where are the gaps? I have not had universal coverage being called or being viewed as an innovation killer. Why would this be assumed to be the case? And what do you think about this question?
Yeah, so she's probably bringing it from the lens of the United States of America. And the United States of America lens is a private lens. For Africa, we view medicine or the provision of healthcare from a public lens. And you must do that because no one can afford a private, no one can afford sort of catastrophic expenditure from health. So if you look at it that, oh, maybe the private health facilities will not prosper, maybe that's the view of innovation killer, but that is not necessarily true. Healthcare is one, and even in the statutes, healthcare has been described as the rules governing health do not govern public healthcare sector; they govern both public and private sector. But it's just where you're coming from. We must put our government into task of ensuring that public healthcare is at its highest level. When that happens, then the private healthcare comes in to complement the public healthcare, because sometimes it's almost impossible for the government to actually take care of all the needs, especially the high-end kind of management. And the public, the private healthcare also helps in ensuring that the standards are not kept low from the public facility under the guise that there is no money, you see. So we must also have that. So the private healthcare sector is complementary, and the role of the government is ensuring that there is a suitable environment for it to prosper, with the ultimate goal being the ultimate goal being the healthcare of that citizen. You get? So if we start from the goal that any citizen anywhere in this country should be able to get quality healthcare. Healthcare is not just healthcare. It is quality healthcare. Then we put our policies correctly.
Right. And actually, I was going back to that statement where, you know, in the private sector, people say that the role of the government is to create an enabling environment so that the private sector can thrive. And then the government will mobilize resources through taxation. And now I hear from you that the role of the government is sort of dual, where its role is to create that suitable environment for its public health services to thrive, or healthcare service centers to thrive, but as well as private sector centers. And it's good to contextualize this discussion. I truly want us to cover the area of inclusion, whether we think that the practice currently is inclusive enough. I know before the Big Four agenda, we really had crazy stories coming up from the northern side of the country, especially when it came to maternal health care. To this day, I mean, in 2020, December, during the adolescent, scientific adolescent health, sexual and reproductive health care conference that happened in Mombasa, we had a woman come from, what was this county? Still Mombasa County. And she had had a baby, but had not been given proper education about her possibility of conceiving while she was actually nursing her newborn. And so she conceived. But her chama women spoke to her and told her that, by the way, you can actually access safe abortion services within a health facility. And she did it. She procured an abortion. But as a result, she actually was publicly ridiculed by the community. Her husband took the baby and left. And she was now called a witch, and so many other horrific things that you can't imagine that is possible in 2020, all because, number one, she didn't have the knowledge. Nobody taught her about sexual reproductive health. She assumed that because I've conceived my baby, I can't conceive again. And therefore, she was brought into the conference to actually speak. And I was just in awe of it all, imagining that, I consider myself a born village, but I've had the privilege to have this information given to me. I thought it was on a platter, but now I'm beginning to realize that not everybody might have had the same opportunity to learn about sexual reproductive health. So do you think that our healthcare information dissemination policy practice, is it truly inclusive, and who suffers most when it's not inclusive?
Yeah, so that's a good question, and we must look at a lot of times we make a mistake of thinking that the healthcare and health policy is the answer to the problems that people are facing. You see, and a lot of times you think there is a magic wand that answers the questions of healthcare and those inclusivity and the services and all. And I do not like to box myself in that narrow space. So I look at it from a bird's eye view. And the bird's eye view starts with several things. Health comes from the community. So I've worked in ASAL areas, and I've worked in Nairobi, and I've worked in Murang'a, and the health-seeking behavior, the health attitudes are very different. So you may find that the health-seeking behavior in where I worked in an ASAL area, for instance, is to get as many children as possible. And when you come down north, then you say, no, there is more need for family planning, so to speak. So look at these two scenarios. One, you are working in this area where the community, it is a very good thing to have many children. So you may not have access to family planning methods, because generally people do not need as from the community family planning. But when you come down here where they are limiting the number of children, for instance, they have, then access to family planning, the demand actually is even more. Then when you look at it from that community view, then you need to, the medical practice needs to be tailored according to that community, you see. So you may take a practice that you think is normal in one area to another area, and it does not fit. Maybe a small example to use is like taking anti-malarious drug, a lot of them to central Kenya, where mosquitoes die of cold, you see, and maybe there's not too much malaria, and not taking it in Western province and Nyanza, where malaria is endemic, you see. So but when you come down now in terms of non-communicable diseases like diabetes mellitus, which are many, are the high majority in around this central Kenya region, vis-a-vis Western. Then, so you see, you must tailor according to the disease burden, so to speak. Then the information dissemination in terms of what are the cultural practices in relation to both genders, so to speak. Then information will get there. Then now comes to the health system in terms of health promotion. A long time ago, there used to be people walking around from the public health department, going home to home, trying to see whether there is ABCD and all sorts of things, including are you immunized? You have this information on where to go for delivery, what to do. So this has sort of gone down, and public health promotion is a very big component that unfortunately was devolved, and some county governments may invest in it and others may not. And so in terms of and then in terms of sexual reproductive health rights, some community practices that were there before, like you have the aunties training the young ones on all manner of things, menses, marriage, and all those community items have fallen off as a result of probably urbanization, rural to urban migration, and those things. So you really need to look at, nothing can be the magic bullet for specific issues. So for individuals, you really need to go back to understanding where they're coming from, which community they're in, where they live, and what is the education background, what is the penetration of education, and whether resources have actually been allocated. For instance, in the Asal region, a nomadic people may have different needs from people who are doing farming, for instance.
Right.
You see? You must tailor their needs according to that. Now, one of the aims of devolution is actually to individualize management of communities, you see. So a county government may have their priorities according to what their issues are, you see. Like, for instance, currently, drought has been declared a national disaster, so to speak. But a lot of the people who are suffering are in the northern and arid regions. So the county governments there may prioritize nutrition, which is a health issue. And therefore more monies may be allocated towards food distribution and you see, so as opposed to down here where maybe diabetes is a problem now, you see. So you must really contextualize any form of management of health, and limiting it to a specific issue, then those ones should be left to individual, for instance, health practitioners who can engage social workers, who can engage counselors, who can engage treatment records and all. Yes.
Right. And thank you for that. I mean, it's good that you bring it back to perspective by telling us to step back and look at the different contexts under which certain things are done. And actually, this being a diversity platform, we are sensitive to cultural demands of different regions and so on and so forth. So I had to ask that question because it really bothered my mind. And I was like, the first time I'm going to have a doctor on board, especially someone in the policy space, I would definitely ask the question. And your answer is actually, it's good enough to help me think deeper as I address these matters. Now, one of the other principles that I came across in terms of universal health care principles is actually adequate, motivated health and remunerated healthcare workers. That is a question that I'm sure you also saw coming. And I just wanted to know whether in Kenya we're doing a good job at it, or what is the problem? And I have to bring this up because, for me, this is a sensitive area. But, why have a doctor on duty who doesn't have enough nurses? What happens at a point of emergency? And, I'm saying this as someone who has been affected by such a situation where I had to live with somebody who was basically hanging on a string, and he ended up resting. but it just felt like I lost 15 good minutes in a hospital that was open, but the nurses were on strike. And I don't know how many other cases are out there. So, Daktari, do we have adequate and motivated and remunerated healthcare workers in Kenya? Is that something that we could work on? And don't think of it politically or anything. It's just like, what can we do if we don't have that? What is the motivation that can be done for those of us who know that we are on the path towards getting into those positions that will be making critical decisions for this country?
Yeah, so I think I had touched on that even as the program started, and just to go straight to the point in terms of what we have been advocating for you to, for us, the way we see it, to achieve an adequate and motivated health workforce in this country, we need what is called a Health Service Commission, whose job, and also a policy whereby all health workers are immediately absorbed after training and deployed to their various workplaces. Health is a very practical career, so to speak. You go and you are not only working, but you are actually working using the skills you are actually directly trained for. And it's one of those things. So to answer your question, we'll go back to the period, the devolution period, and then I'll ask you how many health worker strikes have been there. Yeah, I mean, in the at the onset of devolution, then there have been more than 50 healthcare worker strikes. So that just points to a situation whereby there's a problem. And part of the what has happened following the health worker strikes, part of the almost unwritten government policy is that they have frozen employment of health workers, so that from about the year 2017, then the ratio between health worker and patient is now getting worse, so to speak, because the rate at which new health workers are being employed is frozen. It's almost a deliberate kind of thing, and we have seen that the number you're producing are not the number being absorbed, and therefore when you go to any health facilities, the ratios will be getting worse, actually.
This is crazy.
And for us, it's pretty straightforward. And this was brought to the fore by COVID, whereby the guidelines that we wrote in terms of human resources for health, there's a whole book, were not implemented because they simply said we do not have money to employ. But you see, it all comes from the policy. And if the ratios become poor, then also that has an effect on the service delivery. So basically we have a growing population. The need for health workers will always increase. You can't say that, oh, we have enough. You can never have enough. And therefore, the policy should be towards ensuring that the motivation of the health workers is and maybe because I've been in both sides of the divide, a major issue in terms of health workers issue is the autonomy, and their autonomy that they needed to have to run especially public institutions. This was taken away by devolution. And a small example is that previously a hospital management team used to decide what is needed in the hospital, and they allocate resources to that. Currently now you have to beg the county government to buy a bulb, for instance, because the finances are now centralized. The finances are now centralized at the county level. Actually, what we say is
decentralized. Do you say decentralized? Because before it was under the national government, and now it's in the county government. So it's sort of
actually, and that's the concept I actually wanted to push to you. It has become more centralized, more centralized, such that, and this is actually the paradox, and that people try to prevent. The county governments are now the ones collecting monies from the hospital. Previously, hospitals had their own accounts, and you deposit into that account, and after 3 months, you're given what is called the authority to incur expenditure, and you people decide, okay, yeah, last week we didn't have this, so but now this money is collected by the county government, and they decide when to give you, what to give you, and therefore you have a more centralized, devolved governance. You see, so it's the opposite, whereby now even the health workers who are now devolved, that you belong to the county, whereas they should be more centralized so that they are able to move around easily when necessary. You see, in the spirit of, in the principles of the constitution of county government, of patriotism, of ability to move around the country. So this concept is very important, and you need to look at it that way, that health was not devolved, because the county governments now became the centers of collecting money. And this, as I told you, they did because the county hospitals were improved from the year 2006-7 up to 2013, just at the time, and they became centers of money. And this is what they are focusing on. You see? So we really need, in terms of even that, what you call motivation of health workers, they become motivated when they're able to run the health facilities themselves, and not when they're receiving orders from county governments on, oh, treat this particular fellow. You see? So these are important concepts. You must, a lie often repeated does not become the truth. Health was actually not devolved. It was centralized, because now county governments are the ones controlling the purse, as opposed to the individual hospitals. And I'll give you a very good example. I was the medical superintendent of the Excella district hospital. I had the authority to incur expenditure, meaning I was the one signing for the monies we've collected at that quarter for use at the hospital. When the devolution came, now this has to be signed at the county, and you send, and therefore this form some form of demotivation of the health workers, so that they do not see what the money they have worked for is going into, and when they ask for things, then they don't get, and then their salaries are delayed. And because now you've said they are health workers of the county, but yet the monies to pay them comes from national treasury. So the county government serves as an ATM. You see, money comes from the treasury to the county government. So then they keep it. They keep it. And then after you get delays. We've had some counties where the delays for 1 month, 2 months, you see, and still you still expect that particular person to function well. So these are some of the things that require discussion, you see, so that we do not come to a situation whereby I'll now discuss this issue of strike. Health workers strike because of what is called moral injury. Moral injury. And I'll explain to you. People don't wake up one day and go on strike. There has been a cumulative event of things that have been mistreated. Their salaries have been delayed. Their statutory deductions have not been sent to the relevant bodies, and they wake up. But more important is that they are accused of things they are not in control of. And I'll give you an example. If I am there and a mother comes and delivers and starts bleeding, for instance, I need a drug, and I need a drug to stop the bleeding, and I don't have the drug. And the reason I don't have the drug is because the government has not bought that drug. Then the mother dies. The community will say, I killed the patient, you see, but I had no control of that expenditure and purchase, you see. And therefore, after some time of asking for the same thing, you go on strike. And in fact, if you're on strike, the patient is likely to leave, because they'll go to a place where the drug is available, even if they may have to pay in a private facility. But then they'll start saying, oh, those people are on strike. But you see, in terms of moral injury, when this repeats several times and you start becoming desensitized, then it becomes an ethical issue. So it becomes ethical to go on strike. You see? So people don't just wake up one day and decide, oh, we don't like it. But now, when they go on strike, this issue is politicized. You see, politicians, you see, your doctors, your nurses, your clinical officers are on strike. You see, so yet they do not address the issue that brought that strike along. You see, we have
Yes.
what are called collective bargaining agreements. So when the government reneges on that, and then you go on strike, then you come and say, and that's the reason we decided, no, in 27, just go to jail, so that
I
can't go back
remember that.
again.
I was seeing Kina Dr. Oluga go on the streets, and I was like, surely these people look reasonable enough. But actually, that goes back to the lack of information. It is sad that even we who have gone through 844 do not even understand how these things work. Devolution came when most of us had finished our tertiary level education. And unless you decided to pursue knowledge of the Constitution and what devolution means, when you see a doctor go on strike, you just see negligence. So therefore, I think your path is right, to become a social innovator, to be an advocate of maybe, first of all, demystifying the thoughts and the presumptions that we have, and then also to just continually, thank you for agreeing to come on this platform, but to continually help in dissemination of information that is critical to people so that they understand what happens. I have a young female who wants to actually vie for a senatorial position in Muranga, and I will be supporting her. But when she went to plea her case, or maybe state her case to the constituent members, she was being told, why didn't you go for nomination? The ignorance of it all. People don't even understand how things work. And therefore, now you're telling us that we are having this paradox, and I think I typed it somewhere in the comment, where you're telling us that we have this paradox that we are assuming that, health is a devolved function. Therefore, money is coming from the county government. But we're not understanding that there's lack of autonomy in the management of those resources being mobilized. So it is such a shame that, I knew I came onto this podcast and this session to learn, but it is sad to know how much more we don't know. And if we don't know this much, imagine the many people that follow us, the many people who look up to us to give them information, how much more they do not know. So Asante Sana for... Someone is asking, surely this is a tough question. Someone is asking, why are we ignorant? And another Miss Thierry is saying, amazing conversation. Thank you guys for your comments. Is to say that we may not answer all the questions here. I see another sexual reproductive health question that came. Stories from the OR. What is your opinion on sexual reproductive health rights being taught in schools? Do we as a country need to think that? Maybe you could take that question as we wind up and leave our audience with words of encouragement. I know we've had probably 14, 15 people tune in and out during our live session, but many more people will watch tomorrow, and guess what, for years to come. So this is a good thing that we're having this conversation now. So you could feel free to take that last question and then give us a very nice, positive parting shot, a glimpse of home, a ray of hope and sunshine, something like that. Thank you.
And I like that question that merges health and education. And education is another topical issue that we usually commentate on. And of course, there's a whole CBC debate that I will not go into because, I think it should be overhauled. But in terms of the problem we are having in Kenyans, even as you can see that question, is that we take and we take positions at each end, you see, and we do not come together to actually decide what is best, for instance, for the children. About sexual and reproductive health rights being taught in schools, the first thing we need to do is to have definitions of these things. Some words we use, we don't even know what they mean. Sexual and reproductive health rights, you see. We need to sit down and come up with some form of curriculum and say, what do our children need to know at this level? And we agree, and secondly, we need to also to agree on how do we deliver this information. If some people find out, if people think that it is it's not the way they like it, then you sit down and actually discuss what is the best way to deliver this thing, and do we need to deliver this information. Once we agree on that, then the house and the discussions people have by taking end positions will stop.
Right.
Do children need to be taught ABCD? They do. How do we do it? Then we agree on how to do it. So and maybe we need to move conversations away from you either do it this way or that way, and come up with regular conversations like this particular one. And I'm sure you get a lot of information from it, so that we can all participate towards the development of our country. And we avoid, are we supporting this person? Are we supporting this one? And we focus more on the values. Which value are we supporting? You see, so that you do not box us into one thing or the other. We just do what is right for everyone. So is devolution good or bad? No, it cannot be a discussion like that. There are good aspects of devolution. There are aspects that we tried and have failed and we accept. There are aspects in education that we have tried and we can see them failing. Accept and correct. The only problem is when people take hard stance position and refuse to correct. I think with that, the parting shot of this is that leave the experts to do their job. The ideas on health are by health workers. And we must avoid politicians purporting to be health workers. And I'll give you an example. When COVID struck this country, and we had a calm for 4 months, whereby we were listening to health workers and not politicians. That was one of the best times in this country. You see, there'll be no fights between communities. There'll be no health workers. They were just treating and everyone. A health worker is the only person. Okay, probably not the only person. Let's say it's a person in a position to be a patriot. Teachers, people like teachers, they're in a position to be patriotic. I have worked in Nairobi. I have worked in Machakos. I learned a few Kamba words here and there. I have worked in Isiolo. I have done medical camps in Baringo. You see, so you get to meet every different kind of culture, and we love it. A lot of my colleagues are from all walks of life. That diversity thing that you're telling us.
Yes.
The mix and match in the medical fraternity. My mother-in-law, for instance, when she finished, she was a nurse. When she finished school, like she worked in Wajir for 3 years before now coming to her hometown. You see, this creates diversity. We cannot box people and claim that you want to be patriots, yet you have put rules and regulations that do not facilitate this. If my wife works in Machakos and I work in Mombasa and I'm a health worker, and we are both employed by a system, there should be a way to facilitate that I come and work near her without me having to resign or something. This helps prevent HIV. It helps prevent domestic violence and things like that. You see? So we must look at our policies from a Kenyan point of view, a patriotic point of view. So I think with that, your diversity question is answered. And we must make rules. And finally, we must tell these politicians to stop trying to exclude health workers from the big bodies that run health in this country. We have of late seen healthcare laws trying to remove, for instance, the Kenya Medical Association from bodies like the National Hospital Insurance Fund, from bodies like the Medical Board. And they did pass rules, and this is just to prevent them from, the health workers from pointing out issues that they are trying. So we must stop these bad health amendment laws that they are bringing. We must stop them. And for the people to see and not to be cheated, and listen to the professionals. Listen to the professionals. I think that's the bottom line of it.
Right. Thank you very much. We do have 3 minutes to go. And I don't know where the viewers are coming in from. You guys should have been here at 8 o'clock. But Daktari is going to give us a parting shot with positivity. This is on a personal level, not on a professional level or a policy level, to know how you keep a straight face. Or among our audience, we have both male and female. At some point, medicine, or maybe pursuing this medicine, the doctorate undergraduate course, stopped being fancy. I don't know how you would say that, first of all, have the right intention towards coming to this career. I had a discussion with a mother over lunch hour today as I was walking to KMA, actually, and they were telling me that my doctor started having a wrong attitude with me, and I think something has happened to them, and I don't feel safe with them anymore. So I found a new pediatrician with my daughter, and this one is good. She actually says, my space is baby proofed. Let your baby play. Let's talk. And what is the growth process? And she was just so excited. And I was like, I've had the privilege of having good doctors, thankfully. But do we have the right people in this profession? And what would you say to both young men and young women who want to get into this profession as we close?
So health workers in general and doctors in particular become good doctors when the environment that they are given is suitable. So when you have, for instance, a doctor who is running around all over town trying to make ends meet because, one, they have not been employed immediately after they finish school. They are running around, they're busy, they're trying to get a wife, for instance. They're trying, they may be in trouble, you see, and maybe that said, that does not make it's usually a personality issue. You see,
right?
Have you been taught how to? Have you been exposed? And maybe if I come from my perspective, I learned finesse by what you do doing locum and this is a true story. I learned finance in a private setting, but I learned the art in the public setting. So the complementarity about it. The public sector has many patients of which you have to treat with caution, so you get exposed to a lot of the illnesses. The private sector, as we say the difference, you have to treat people in a special way. You get what I mean? There is a way,
right.
Because there's also that aspect of, by the way, if you chase away our clients, we will also chase you again, the profits go down. But that means that they put on some form of quality, and they also invest in what is called public customer relations, so to speak. Not that you can't do that in the public sector. It's easier in the private sector because, one, the patient load is little and the environment is there. So we must also promote the people to work in both sides. Then you get the both of both worlds, and the patient benefits the most.
Right.
The day, with this will be the last point. The day I started wearing a shirt was the day I used to be very good working in the public sector, and in Machakos they'll say, oh, that guy is a good guy. But when you go to the public sector, I used to work in a private hospital, and then one day a patient reported to the head of that private unit that today I'm seen by a street man. You get what I mean? Probably because of the clothes that you're wearing, you're thinking your brain is very good. And that's the day I had an aha moment. I said, what? They're looking at what I'm wearing, you see. But when you're treating people in the other sector, they're not looking at it. As long as they get well, they go home, and the public said they're fine. But now this finance thing, which is also important. So you improve both ways. So I think it's individual. And doctors improve with mentorship, with opportunities, and it is the role of the older to actually mentor the younger ones.
All right. Thank you so much, Daktari. We really appreciate your time. We know you're still in the office, and, well done. I've seen your students here. I've seen so many Daktaris. I hope I get to retain them whenever I discuss healthcare matters, but usually we discuss about governance, and looking forward to the next, next week's episode. Asante sana. Have a blessed evening. And thank you to our viewers, for those who managed to stay in. I still see somebody sending a comment. Oh, it's YouTube, and YouTube has sent us a comment. Have a blessed evening, Daktari. Thank you.
Asante sana.
All right. Have a good one.